Thank you very much, Chris. It's a pleasure to be here, and thank you for inviting me to be part of this session. The controversy that I will discuss today is DALT is a big bubble worth the trouble. Waiting for the slides to come up. I have no financial interest in any of the products that I'll mention in this presentation, unfortunately. I'm going to talk first about the investment. If you're a corneal surgeon, you're not doing DALT, what does it take to begin performing DALK? And then what is that return on the investment? We'll talk first about the expense. Does it cost much? The answer is no. Very inexpensive. The only instruments I had to buy when I started performing DALT were the Fogla set that Burgess is here. Hopefully he'll give me a cut of the proceeds for mentioning these instruments. They are very good available through stores. But all you need is something to inject air into corneal stroma, something to make a tract to inject, to pass the air cannula into, and then right and left going scissors to excise the corneal stroma. So there's little startup cost in doing DALK. However, there is an investment in terms of time and effort. This has a steep learning curve, this procedure does. And it's exemplified by this video. This is for those of you who are not familiar with DALT, we're looking here at a bared desmase membrane. And you see I'm excising some of the residual stroma that remains. This procedure is performed, as you know, for patients who have normal endothelium but unhealthy stroma. Let's say a patient with keratoconus or a patient with corneal scarring. And here you see I'm excising this last little piece of stroma here. Spent about 30 minutes exposing desmase, and boom. I'm pretending not to see that, and I'm continuing to cut. And my fellow said, "What was that, Dr. Aldave?" So at that point, you can either continue, or in this case, then convert to a penetrating keratoplasty. So unfortunately, in spite of your best efforts, many times you're not able to complete the surgery successfully, and you've already put in 30 to 45 minutes to expose desmase membrane. So it can be a frustrating surgery to learn. Because I'm not alone in that complication. Here's some common complications following DALK, or that happen during DALK. You see right at the top here, desmase perforation in about 14%. Like any other surgery, though, as you become more facile with the technique, the incidence of this complication and others does go down. So what's the return then? It's more difficult to perform. It takes longer. We saw in the video sometimes results in a unsuccessful attempt to retain desmase. What do you get out of doing it? Well, number one, increased donor cornea utilization. This is a paper that was published in AJO in 2011. And you see here, in this case, this group took 50 corneas, and they took off desmase membrane. And that desmase then went to patients who had Fuchs endothelial corneal dystrophy for performing DMAC. And then they took the epithelium and stroma and then used that for DALT, for patients who, again, had disease involving the stroma, but with healthy endothelium, such as keratoconus. In this case, you could really double the number of recipients if you do this technique for DALT and then using desmase for DMAC. So you have increased donor corneal utilization if you're a DALT surgeon. If you have a donor with good endothelium, as you just saw, you can use it for DALT and DMAC, or you can cut that cornea that might be keratoma, use the anterior portion for an anterior lamella keratoplasty and the posterior portion for DSAC. If you have donor cornea with poor endothelium, again, DALT increases utilization because you can use that for DALK. We are going to strip off the donor endothelium before we use that donor cornea, so it doesn't have to have good endothelial cell count. Or you can use that donor cornea with poor endothelium as a carrier for the Boston keratoplastosis, for example. What about visual outcomes? Do people see as well after DALK as they do after penetrating keratoplasty? This is a paper that was published in Ophthalmology 2011. Just looked at this question. It's a randomized study. The bottom line is they found that patients who had PK had better vision at 3 months and 6 months, but at 12 months there was no difference, you see by the p-value, between the DALT group and the penetrating keratoplasty group. And if you look at the improvement in vision, there was no difference at any time point that they looked at. What about post-op complications? This is a paper that was published in Ophthalmology 2012, looking at long-term results of DALK versus penetrating keratoplasty. Here we're looking at post-op complications. We'll note one thing that was a surprise to me when I started doing DALT, and that's that the incidence of stromal rejection is much higher in DALT as compared to penetrating keratoplasty. Just as if the recipient's body prefers to reject the endothelium. If the endothelium is retained, then they'll go ahead and reject the stroma. And this could be a serious condition. Many times I think people underestimate the severity of stromal rejection. The biggest advantage of DALT, though, of course, is the fact that you eliminate the risk of endothelial rejection because the recipients retained their own endothelium. Whereas in this study, the incidence of endothelial rejection in the PK group, about 15%, which is in line with other previously published studies. Here's a patient of mine for whom I performed DALT, a young girl about 16 years old with keratoconus. Surgery was removed in a timely manner, but she developed this intense inflammatory response that you see with subepithelial and intersternal scarring. Here in retroillumination, we can see the extent of the vascularization. This is stromal rejection at its worst, but I have several patients who had such bad stromal rejection, I subsequently had to go on to perform a penetrating keratoplasty. And now you're performing it in an eye that has a vascularized close to 20 rim, further increasing the risk of subsequent rejection. So it is not a benign thing. What about endothelial cell loss and graft survival? This is a table from a paper that was published in Ophthalmology in 2011, again comparing adult to penetrating keratoplasty. What we see overall is that the endothelial cell loss in the adult group at the year is about 19% as compared to 28% in the penetrating keratoplasty group. If you take out the eyes that had perforation of Descemet's membrane during surgery, the endothelial cell loss in the adult goes down to 13%, again compared to 28% for the penetrating keratoplasty. Another study looking at endothelial cell density, adult versus penetrating keratoplasty. And in this study, the endothelial cell loss at 2 years with adult was only 7%. And we compare that to data from the cornea donor study, looking at cell loss following penetrating keratoplasty at 2 years. Depending on the age of the donor cornea, the cell loss you see is either 31 or 44%. Again, compared to 7% with DALK in the previous study. Let's take it out to 5 years now, looking at cell loss. Comparing penetrating keratoplasty to DALK, we see at 5 years the cell loss of PK estimated to be about 50%, DALK only 22%. What this means is if you follow grafts out over time, you do a penetrating keratoplasty or a DALK for a 20-year-old keratoconic, how long is that graft expected to stay clear? If we're looking at median graft survival, it's indicated by the red horizontal line. With a penetrating keratoplasty, median graft survival estimated to be about 17 years. With a DALK, estimated to be approximately 49 years. So you tell me which technique you'd rather have if you're a young person with keratoconus. This is a paper came from Italy, Sinicolis group, looking at long-term graft survival. This is 660 DALKs, a huge series. And looking at this Kaplan-Meier survival curve, it's about as flat as it gets. So the median graft survival, or median follow-up, of 4.5 years in this study, graft survival over 99% of this group of DALKs. This, again, I think is one of the most compelling reasons why all surgeons should be performing DALK. So in conclusion, as far as investment, the expense is negligible. It really doesn't cost much to buy the instruments for DALK. As far as time and effort, it does require more OR time, and it is technically more difficult to perform than a penetrating keratoplasty. However, the return makes it worth it as far as greater donor cornea utilization, visual outcomes that are equivalent to penetrating keratoplasty, elimination of endothelial rejection, and significantly lower endothelial cell loss and longer graft survival compared to penetrating keratoplasty. Thank you very much.